Hello, everybody. My name is Chioma Nnaji. I'm a program director at the Multicultural AIDS Coalition, which is a grassroots nonprofit organization in Boston, Massachusetts. We primarily provide HIV, STI screening, education, and prevention services to communities of color. And I'm excited to be here. I'm excited to moderate this panel with these beautiful ladies. Today, we are going to be talking about Black immigrants in the U.S. and HIV. So before we get started on our topic, I'm going to ask the ladies to please introduce yourselves, share your name and the work that you do, and why do you think this topic is important?
Okay, do you want to start with me?
Sure.
Sure. Okay, first of all, thank you, Chioma, for convening this panel. I think this is a very important topic. My name is Bisolo Jigatu. I am an assistant professor of medicine at Harvard Medical School and an infectious disease specialist at the Brigham and Women's Hospital in the Division of Global Health Equity, as well as at Mass General Hospital. I've been an HIV care and treatment provider for about 15 years now. Many of my patients are immigrants. Many of them are Black, and they come from sub-Saharan Africa and the Caribbean, and they have unique barriers to care and unique issues with care and treatment that oftentimes we don't talk about at meetings such as this. So I think it's really important that we talk about some of those issues and hopefully think about interventions and ways to overcome some of the problems that people are facing.
Hi, my name is Yolani Dolmo. I work for Multicultural AIDS Coalition for Women Connecting Affecting Change, which is our drop-in center. Our target population are women who are substance-using women, survival sex workers, women with mental health issues, and basically trying to empower these women to better their lives.
Hi, and thanks for inviting me into the space with this incredible panel of women as well. My name is Josephine Ayankoya. I work as a community programs manager for Bridge HIV, and we're a clinical trials unit of the San Francisco Department of Public Health. And I also am a member of AVAC's PX Work program, which is essentially a group of domestic advocates doing work around research and representation. And I think this topic is incredibly important. I think when you look at the HIV epidemic, both within the U.S., both nationally or internationally, and then in most developed high-income nations, by and large, people of African descent have experienced disparities. And I think there is not enough attention paid to the specific barriers as it relates to like citizenship status or immigration, income, and all that. I think oftentimes it's simplified, which I'm sure we'll get more into. So I think it's great to kind of shed light on women of immigrant and migrant experiences.
Great. And I think you opened the discussion to what I would pose as our first question, because often in doing this work, I find that the first question that people ask me is why.
Mm-hmm.
Why do you feel as though Black immigrants need to have a special sort of or need to have attention just as well as other populations, and why are Black immigrants? Why is it not okay to have Black immigrants a part of the African American / Black sort of work that's happening? And so I want to pose that question to the group. Why do you think it's important? Do you think there are differences between U.S.-born Blacks and foreign-born Blacks? If so, what is it? What are those differences that make it important for us to specifically address the needs of Black immigrants, as several of you have already said?
I think it's really important to, number one, become aware culturally, understanding the culture.
Exactly.
Yeah, and also, the importance of understanding also that racism, sexism, poverty has a lot to do with the lack of information for a lot of immigrant population.
Excellent.
So I think that's important for people to understand the magnitude of the issue, because I don't think that people understand how Black immigrants, or how many are actually impacted both by HIV risk as well as, actually contracting HIV. First of all, Black immigrants are a growing population within many jurisdictions around the U.S., and they tend to be what we call sort of hidden populations because the data doesn't really disaggregate by country of origin. So everybody just thinks they're all just Black.
Right. Majority of surveillance data.
Exactly. The majority of it. And when you look at, across the country at issues of HIV rates, and you look at rates between Native Black individuals versus immigrant Black people, you see that there's a higher HIV rate amongst Black immigrants, but yet people don't really know that. And particularly when you look at Black immigrant women, you notice that. And if you look at some place like Boston, Massachusetts, where almost 30% of the Black population within Boston City itself are actually non-US born, we definitely have a disproportionate impact amongst non-US born individuals, where particularly if you look at women who have been diagnosed with HIV in the last few years, more than 70% are actually non-US born. So in the midst of that, what people try to do is they try to develop interventions that are standardized to what we think Black American women are used to and what their experiences are, without even investigating what the experiences are of all these women that we lump under Black immigrants when they're coming from different continents, different countries, they speak different languages. And I think Yolani brought up the important point of intersectionality. I mean, we're talking about multiple layers of oppression where you have people who've experienced racism, sexism, xenophobia.
In different cultural contexts.
Exactly. Low English proficiency and have been discriminated against based on their accents, how they, their cultural norms. And it's like you really have to tease through all that to figure out how interventions need to be developed.
I guess just to add on, because I think those are two really great responses. I think by and large as African people, we're definitely all connected, but there are differences. I think that even the term African, that describes over 50 countries with hundreds and hundreds of ethnicities, that in and of itself. And I think that in the experience in particular, we're all kind of lumped into this Black category, like we talked about, or African American. And people are like, well, there's confusion, like, okay, does African American mean you're African and you're in America? Does it mean you're several hundred years here? There are a lot of differences, and I think that a part of that is most of that is definitely tied to our history of oppression. The fact that we aren't represented. We can look at census data or other tracking mechanisms where you can specify if you're if you're Asian, if you're Latino, and then other ethnic groups, you can specify exactly where you're from. And Black is used to characterize millions of people from across the world. So I think that's way too simple of a term, although I recognize that there are shared experiences of oppression, shared experiences of resilience as well in the face of that oppression that make us connected. That said, I think it's important, like you all were saying, to kind of find culturally competent interventions for what for the different groups. I think that, and I agree, I think there's no way to know what those differences are if they aren't explored or if people don't even know we exist. There are people who are foreign-born, there are people who are first generation, there are people who are a combination of both, there are people who've been here for hundreds of years, there are people who are Latino and African and European and African. So I think all those come with different sets of circumstances that increase the risk, and also different cultures that influence how you perceive sex and risk-taking. And I think that's why it's important to recognize those differences. So those are my thoughts.
I think, we've talked about sort of differences as it relates to culture, how we understand health, how we understand HIV. You brought up an excellent point, just even how do we talk about our bodies and talk about sex from different cultural domains. And I think we also touched on sort of what does it mean to engage these populations in prevention, and about, we know what some of us know what the increasing rates are happening in terms of Black immigrants. But there's also a clinical side, right? And so I think, it's important to talk about, because I think also, in the work that I do, that, there's an assumption that everybody should be treated the same way once they hit the clinical doors, right? And so there's not an understanding in terms of, yes, there's differences to get people engaged, to educate people, to prevent, but once they hit the doors, there's also differences that you have to engage in and you have to recognize. And so those differences are around sort of knowledge of treatment. Those differences are around sort of acceptance of certain treatment because of cultural understandings and cultural domains. The need to, I think also it's important to bring up the need for providers to have an understanding, and Basola, I know that me and you have talked about this a lot, have an understanding about the transnationalism of these populations, and so these populations are not only here in the U.S., but that they are traveling back and forth, and so providers having a greater understanding in terms of what does that mean in terms of their medication and adherence, and I think definitely a bigger picture, which will take me into my next question, is around being able to understand what does it mean to have a Black immigrant living with HIV and some of the challenges around partner notification, some of the challenges around disclosure, some of the challenges around being willing and able, because I think being able needs to be underlined in terms of what are the repercussions to even disclose, and what are the repercussions to even disclose to your partner who might have been the one who gave you HIV in the first place. Because what we know in terms of the epi around this disease is that Black immigrants are primarily Black immigrants, I can say African immigrants, because I think it's a little bit different when you talk about Haitian immigrants, but primarily Black African immigrants are their transmission is through heterosexual sex. We're seeing more women come to the door, and so we'll question, well, where are the men, right? Because heterosexual sex means men, right? That's what that means, right? So where are the men? So when we talk about sort of clinical interventions, I think there's a lot that we can do around that. But I wanted to specifically bring up the new sort of information out there about the vaginal ring. And it being a promising intervention, biomedical intervention for women to prevent HIV, right? And so the idea is that it works just like a birth control mechanism, and it allows women to have more power over their bodies, and also allows women who are in these situations, and I know this would extend past just Black immigrant women, because the work that you do also, Yolani, is with sex workers,
Yes.
but to have some type of control over transmission, getting HIV. So what do y'all think, because that study, Basola will clarify the study, because I know she has a lot more information about it than I do, was done on the continent with African women. And so my question would be, I don't know if they even talked about if there were any cultural challenges around that. And then my follow-up question would be, would it look, to the entire panel, would it look different for African immigrant women who are here in the U.S. or Black immigrant women here in the U.S.?
Okay. Well, let me just make some general comments. Right. First of all, if we're looking at Black immigrants here in the U.S., unfortunately, we don't understand forward transmission within those populations yet. Okay, and by that, what I mean is that we don't know if women are contracting HIV here. The vast majority, we believe, are actually contracting HIV before they come to the U.S. and are getting tested here. Okay, so if we're thinking
finding out about their diagnosis,
right, finding out about their diagnosis here. So the issue is we have to ask ourselves, what type of interventions do these women need, or men, whoever it is, okay? So let's talk about the whole microbicide issue, and I'm sure I don't want to take up too much time on that because, obviously other folks have comments. So with microbicides, we know that there's been a lot of disappointment with microbicide trials, okay? And so that's why these two trials, Aspire and the Ring study, are so important. But the reality is the level and decreased risk was not optimal, okay? Because largely, right? No. So let me give the data. So let's take the Aspire study first. That one, it was over 2,500 women, 4 countries: South Africa, Uganda, Zimbabwe, and Malawi. Okay, and what they found over the entire group was there was a 27% decreased risk. The Ring study, around 2,000 women, just South Africa and Uganda, and around 2,000 women in the study, and there was about a 31% risk decrease. But when you look within the age groups, you see vast differences in both adherence and the efficacy of the vaginal ring. Just to explain, the vaginal ring is comprised of dapivirine, which is an antiretroviral therapy, different from the other microbicides, the tenofovir gel that we were using before. And the interesting thing is, with the tenofovir gel, in those studies, we were asking people to, HPTN, the HIV Prevention Trials Network, and the microbicide trial unit, they were asking them to take it pre-sex and post-sex, okay? So they said to themselves, well, women are not adherent, they're taking pre-sex or post-sex, so let's give it a ring. So as you explained, Chioma, it's just a little, a round thing, looks like a hair, something you put a hair clasp or something, and it has the antiretroviral therapy in it. So in this study, they found that within the group 18 to 21, there really was no efficacy in the Aspire study and only 15% efficacy in the Ring study. So what's going on with these women? Is it an issue of non-adherence? Probably, but why? Now, if you look at the qualitative data from the other studies, it was really about women saying, you know what, this could cause side effects. This could inhibit something in me. And even we have to think about the fact that just because you're giving someone a ring to insert, it doesn't mean well, not only that they're not doing it correctly, they found efficacy actually increased, so over time. So you're right, there was an issue of knowing how to insert it correctly. But the issue though is, do these women really feel empowered to use anything. You know, it's not just about, pre and post. Exactly. It's not just about having the technology. Do I feel empowered to take this on? Especially a young woman, an adolescent woman, okay? So I think that there are many issues here that we need to figure out before we jump into transferring it to other populations. I understand your point, but I'm just saying.
I was going to jump actually onto something else, because to me it speaks even greater to those of us doing the work. Right?
Absolutely.
So I think that you're in a position where a lot of people are in a position where they're really engaged into this clinical stuff, right? They're really engaged into this biomedical HIV prevention work, and can dissect the nuances of each one of these studies, right? Versus, I'll speak for myself, versus we get these informations in very fact sheet. You know what I'm saying? Like, it's effective, now we all need to use it kind of thing, right? And so part of it is, ownership as an educator, but the other part is how are we even getting the information out there so that we can accurately say to our clients, yes, it's out there, but. Because right now, it's just that it's out there, it's a promising new, biomedical HIV prevention method, it's something that we need to do, that's the conversation that's happening versus these are the nuances of the study, and these are what we need to be concerned about, and this is how you communicate that to your client. So I don't know, Yolani, Joseph,
Yeah, I just so I kind of want to go back to some of the things you mentioned earlier about sort of first I want to say I think what you're touching on is critically important. Like, we can't have the biomedical without the behavioral, without the social, the structural. Everything happens in the context of something, and we have to understand that. I think that it's great that there are clinical interventions that happen. It's great that new technologies and new techniques are being developed, but they ultimately will never reach optimal, no matter how good the use, whether it's PrEP, whether it's microbicides, whether it's adhering to treatment. If people don't have a full the knowledge of it, or people aren't invested in it, or if there are cultural challenges or social challenges or structural challenges especially that kind of inhibit that. Right. Yeah, if you can't get access to care, then how can you use PrEP and adhere to it and get your levels down? As far as the Ring study specifically, I know I had a lot of similar questions. From what I heard in sessions and asking questions, I know that they had in-depth interviews with both in focus groups and individually. I know that there's a bigger sort of qualitative or bigger survey coming up. So I am really curious to kind of see because I know that those questions were asked. And I know that in a session last night I asked about the younger women in particular, because that kind of was concerning to me, given that the younger women, especially in the African context, are at some of the highest risk for new infections. And from what I heard, if I recall everything correctly, they plan to seek out the women who maybe didn't adhere as much and find out more about why they weren't adhering. So I will say I'm just curious to see what they have to say about that, and I know there's more to come. And I think I don't want to say it's too early to tell, but I think there's a lot more that hasn't been revealed. And I think some of the things that came up were, at least as far as the behavioral social things, were that when there were situations where male partners were on board or male partners came in and got, they were invested and interested in learning more, or even older women in the community who were respected, that helped with some adherence, I think. I'm not sure the exact amount or percentage, but that it helps to have that community buy-in
we see
with that as well.
So HIV prevention.
With HIV testing and a PMTCT prevention of other trials of transmission context, we see the same thing. We have partner support.
So I think it's but I guess I was excited because of past failures or past disappointments with microbicide research. I think it's still a step in the right direction of saying this is data to say we can go forward and do more studies. So I'm happy with that. I do agree that it wasn't like we had an intervention 100% of people were protected, and I think that hopefully with time adherence and the effect will increase. And I guess as far as the whole empowerment piece, I think that's a very interesting concept, especially within the context of clinical research. It's hard for me to say a medicine makes me feel empowered. I think empowerment is it's complicated and it has several different layers. I think it is cool to have the idea that there could be an intervention that women can have more control over, and that may or may not. I think it's cool to have interventions that women can use maybe without disclosing to their partner. But I still wonder, what if men can feel it? Although some have said that you can't feel rings, some said you could. So I think there's a lot of different things. I don't know that I think to make a claim that a medication or microbicide could lead to I feel empowered now. I think there's a lot more that goes into empowerment, all the social, economic issues surrounding women's situations, both in the African context as well as in the American context within the African communities. So I just think there's a lot more to go into that. I think it's nice to have tools, but I also think that we have to constantly think about with these clinical trials, with these breakthroughs, like what does that mean, and what context is it happening, and how is it going to scale up, and what other issues need to be considered in conjunction with this, because it's not enough to just say, hey, here's an intervention that works. If we are not talking about things like gender violence or gender inequality or access to care or poverty.
Exactly. I don't know, Yolani, did you want to add?
You know, for my particular population, I think any information is power. You know, it's specifically for our survival sex workers. If they're given tools to protect themselves, then, you know, a little bit is better than nothing.
Yeah,
you know,
definitely.
so.
Definitely.
And I think it's more than a little bit. You know, when I gave the data, I really tried to be very clear that this is about adherence, right? So in the older age groups, you know, there was like 61% adherence. I mean, 61% efficacy. You know, because they were actually using the ring and they were using it appropriately. So this is definitely a tool that could work, we think. But we just have to understand that it's much more complicated than just handing somebody a tool,
Right.
you know? Just like condoms. Condoms work. You know, lots of things work, but it really is about understanding the populations you're working in, and in a clinical trial sense, understanding who it is that you're enrolling in these populations, where are they from, you know, what are their cultural norms, what do they believe about inserting something into their genital tract, you know? I mean, these things are all important, and at least from my work with like the HIV Prevention Trials Network, it seems to be there's a little bit more awareness now that you must understand these issues better. So I feel like, you know, things are going in the right direction, but I do think there are going to be differences in different populations, certainly amongst, you know, immigrant populations or, you know, Black women here in the U.S.
So how much is there a push, because I don't know this and I'm asking, because these trials tend to be majority outside of the U.S. I know a lot of work comes through Fenway but in other sort of national entities. But how much of this, in terms of happening here in the U.S. context, how much is there of a push to get immigrants into these clinical trials?
I think, well, at least I know I've asked a question a lot about like the fact that there are disparities within the U.S. Although our numbers, like as a whole population, aren't as big as like say a country where there's super high prevalence and incidence. We have disparities. I think what I've always been told is like, well, we don't have enough numbers. Like we won't have enough people to show the effect. So I think, I guess from my understanding is that because our populations aren't small, they're big and mighty and amazing. But within the context of America, there aren't as large of numbers. I don't know like how, and then also because the context is different, like living
Which is even why I would, you know, say, you know, that's why I'm posing the question. I mean, part of it, and I think that you all brought up some excellent points around, you know, you can't just do what's happening on the continent and bring it here and think it's going to work. There's a different context. And so part of, you know, recognizing, and I know there's a big push in getting brown and Black people into research, brown and Black people into clinical trials for the same exact reasons that, you know, we can't continue to just only include and recruit white men or white people. So needing to be able to diversify our sample size and make sure that it represents, you know, the populations. And so to me, it makes sense if we are also talking about within a U.S. context, and we know that there are increasing numbers of immigrants, you know, and I'm not just talking about Black immigrants. We can bring in Latinos, you know, there's an increasing number of immigrants here in the U.S., and these immigrants are coming from areas of high prevalence of HIV and other. I mean, we haven't even talked about hepatitis B amongst African immigrant population, but that's another show. And so, you know, is there a possibility to really start having critical conversations around increasing these populations, even in the U.S. studies that are done?
We have to acknowledge that most brown and Black people are very suspicious of trials, you know, so, and based on the history, I mean, it's been really frightening. So it's about informing them. It's about really, you know, providing that information to let them know that, listen, this is safe, this is for our people. But there's such suspicion that it makes it really difficult to recruit people of color.
So I think that from an NIH, you know, and a funder standpoint, it's really an issue of what's practical and what's feasible. You know, it's great we have these discussions, and I think that, you know, a case can be made to go after, particularly if there are as I mentioned, around the country, there are certain jurisdictions where there are certainly increased numbers of Black immigrants and increased rates of HIV within those immigrant groups. But when you're looking at these clinical trials, which are very expensive to do, they basically not only want to enroll, I mean, they want to make sure that you'll notice a difference between the two groups.
Right.
You know, so somebody's got to contract
Or else
HIV.
it's not, right?
Right? or else you basically wasted,
Right,
you know,
right.
you essentially
Millions.
wasted your money.
Right.
So these, I mean, it's sort of the nature of the clinical trial, you know, and it's not to say at Fenway, they are definitely, you know, recruiting for various, you know, microbicide trials, for other trials, and, you know, there are a number of things that are going on there and at other centers around the U.S. But as with a lot of the PrEP studies, I'm sure we could talk more about some of them if you want to. You know, the ones that involved women, a lot of them were African women, and yet then the recommendations came down for, you know, for high-risk women here in the U.S. to, you know, use PrEP. So it's not like they went and replicated the study amongst women necessarily here in the U.S. They extrapolated the data.
Which is still a problem.
Yeah, I mean, I think it's a problem. I'm not saying it's not a problem. I understand there are lots of nuances. There are unique issues. There are unique barriers. You know, there are lots of nuances to what you're saying. And I think we could have further discussions about that. But I think we also just have to realize what's happening, you know, and understand that, okay, we as people who do community outreach, who are healthcare providers, we have to be the interim person to kind of explain to patients or our clients or whoever that this is why we think this will work. This is why it may not work for you, you know, and kind of give them the broad range of options that are available. And I do spend a lot of time with my patients who come in for PrEP and explain the studies, you know, in a way that's digestible for them, and they can make an informed decision about whether or not this is something that's applicable, you know, to them.
So it's a lot. We said a lot. I think we touched on various topics, and we weren't able to get probably as deep as we wanted to. But I think, you know, the purpose of this is really to sort of put things out there in terms of what we need to continue to discuss, what we need to continue to have in the forefront. Because I do believe that a lot of the topics that we brought up, a lot of the issues that we brought up today is not in mainstream conversations, including, you know, international and national conferences about HIV, that the immigrant experience in the U.S., the Black immigrant experience in the U.S. is not representative. And so for us to continue to have the conversation, I think will allow it to, you know, move. I want to say upstream, but, you know, we're upstream. So we'll allow it to move in spaces where we can really start doing a lot of action around it, right? So I want to thank ladies. I want to thank you all for joining
Thank you.
this panel. And so until next time, until next year.